presenters beautifully presented these topics, which seem to be very dry, but the content was very apt, and I'm sure it will benefit the PGs immensely. Thanks a lot.
Thank you, Dr. Nitin.
We'll move on to the next session, which is a short case presentation. A 32-year-old female with a left-sided ICD, intercostal tube. And I would like to invite the external examiner for this case discussion. We have a very seasoned examiner with us, Dr. Devlina Goswami. Ma'am is professor at All India Institute of Medical Sciences, New Delhi, and ma'am's area of special interest are difficult airway, pediatric, maxillofacial, ENT, and obstetric anesthesia. The moderator for this session, we have our Vinish Arora, who is working as a senior, Dr. Vinish Arora, who's working as a senior resident in the Department of Anesthesia. And the case will be presented by postgraduate student Shreyash. Over to you, ma'am, for the proceedings of the session.
Ma'am, you're mute, ma'am.
Thank you, Team APPEC, for having me here. And I'd request Dr. Shreyash to begin with the case. And Dr. Vinish will be summarizing at the end, right? So, Shreyash, can you present the case of this female 32-year-old with a left-sided intercostal tube?
Good afternoon, ma'am.
Good afternoon.
Of Mrs. Pushpa, a 32-year-old female resident of Munirka village. She is a domestic help by occupation. She herself is the informant for the case. The patient was received in the emergency department of RML Hospital on 1st November at 9 p.m. with a history of an accident. She was walking to her work whilst a speeding biker headed her way, lost control of the handle, hit the bike. The handle of the bike hit her on the left side of the chest. She had complaints of chest pain and difficulty in breathing on presentation. The pain was acute onset pain on the left side of chest, which was sharp and stabbing in nature, non-radiating, worsened after coughing and deep breathing, and there were no relieving factors noted. There was no history of loss of consciousness, vomiting, or ENT bleed noted. No history of any reduction in limb movement or pain noted.
Yeah, Dr. Reyes, I'd like to interrupt you here. Why is it important to have the history of loss of consciousness, vomiting, and ENT bleed in a patient who has presented with trauma?
Ma'am, since in our case, the patient is presenting with a road traffic accident, we must rule out any possibility of head injury. So the symptoms would be suggestive, then we would have to go for a CT head if needed. And ma'am,
and why is the history of reduction in limb movement important for a patient who has presented with shortness of breath or difficulty in breathing? Any association between these two things?
Primarily in case of any fracture of a long bone or any bone for that matter, the pain could be causing a mild amount of tachypnea. But in case of major long bone fractures, there could be a possible fat embolism, which would lead to a sudden deterioration in the oxygen saturation and reduction in the consciousness status of the patient. The patient would present with an altered state.
Yeah, so there are three important things, three important characteristics of fat embolism, which may not develop immediately, but it may take some time. One is respiratory difficulty, second is altered mental sensorium, and third is petechiae. So it is very important to rule out this part, fracture of the long bone in any case of trauma, which presents as respiratory distress. Yeah, you can continue.
The general physical examination of the patient was conscious, oriented to time, place, and person, mildly agitated and sitting up. The blood pressure was measured in both arms in supine position, and it was 96/58 mm of Hg. The pulse was 128 per minute, normal in rhythm, volume, and character. No radioradial or radiofemoral delays were noted. The respiratory rate was 28 per minute, which was regular, and the room air saturation of the patient at presentation was 91%. Pallor, icterus, clubbing, cyanosis, edema were all absent, and the patient was afebrile.
Okay. So what did you do for this patient? When you saw that the patient has a respiratory rate of 28 and a saturation of 91, sharp pain on the chest, what did you do for her?
Ma'am, initially, ma'am, we went with the ABCDE of the survey. We checked the airway, breathing, and circulation. We checked for disability and exposure. Then we started vital monitoring, which we've mentioned. Ma'am, we started with adequate oxygenation at 6 liters per minute using a Venturi mask. I secured an IV cannula, wide bore 18 gauge cannula. I sent samples for blood grouping and cross matching. And routine samples with complete blood count and liver and kidney function tests. IV fluid was administered to the patient for compensating any dehydration. And while doing this, the patient, I prepared the patient for a chest tube insertion and obtained a written informed consent after explaining the patient of the procedure and the complications that could possibly occur.
Was there an attendant present with this patient? Whom did you inform and from whom did you take the consent?
Consent was taken from the patient. The patient didn't have an attendant at that point of time. The patient was brought by bystanders.
Okay, but she was fully conscious, as you have mentioned in the history. She was able to understand, so that is important. Yes, continue.
Ma'am, we conducted the respiratory system examination of the patient. Ma'am, on percussion, a hyperresonant, ma'am, on inspection, the rate was 28 per minute. Shallow, regular, and abdominothoracic. Diminished chest movements were noted on the left-hand side, and use of accessory muscle was also noted. On palpation, ma'am, the findings were that the trachea position was midline. Unequal chest expansion was seen. Left side was reduced compared to the right. There was a tenderness that was present on the left side of the chest. Apex beat was felt in the fifth intercostal space in the mid-clavicular line, and crepitus over the left base was felt. The tactile fremitus was also decreased on the left base.
So, why was this crepitus present on the left base? Can you explain that? The reason for crepitus, yes.
Likely due to the road traffic accident, ma'am, there would most likely be an underlying rib fracture, which could have caused a subcutaneous emphysema, which would present to us as a crepitus.
Okay, so and this decreased tactile fremitus. Tell me a few conditions where you get decreased tactile fremitus.
Ma'am, the tactile fremitus could be decreased in case of a fluid accumulation on the side due to blood pooling there, or any pus, or even pleural effusion.
See, most of the time, tactile fremitus is transmission of the sounds, right? Which you can palpate. So it is the presence of air which causes decrease in the tactile fremitus. So, yes, pleural accumulation of fluid in that cavity might also lead to decreased tactile fremitus, but it is mostly emphysema, pneumothorax. Accumulation of air will cause more decrease than fluid, and it is actually increased in conditions of consolidation. It is solid medium, right? No fluid, no air. So mostly it is decreased when there is accumulation of air. You can continue now to the next slide.
On percussion, a hyperresonant note on the left apical side of the chest was noted, and dull note was present at the basis. On auscultation, the findings were confirmed.
I'll again interrupt. Where do you get hyperresonant note and where do you get dull note? Conditions. Just enumerate a few conditions. Yes.
And a dull note would be in case of a fluid accumulation, whether it could be blood or pus or effusion.
I didn't get the hyperresonant. There was a break in voice. Sorry.
Hyperresonant would be noted when there is an increase in air, a pleural, a pneumothorax presentation.
Yes, also it will be increased if there is an emphysema, if there is emphysema or asthma, right? Yeah, not so much as a pneumothorax, of course. Yeah. Continue on auscultation.
On auscultation, the findings were confirmed with decreased breath sounds on the left side, and crepitations were heard on the left base.
Okay.
The other systems examinations were normal. Cardiovascular S1, S2 was heard. No murmur or added sounds were heard. Abdomen was soft. No guarding or rigidity was present. And the CNS system was also normal with normal higher mental functions and all reflexes within normal limits.
So the patient had a trauma on the left side of the chest. There was there was sharp pain on that side, right? but the cardiovascular system seems to be fine. So all these findings lead to suspicion of only one system being involved. Which is it?
Primarily the respiratory system.
So what did you do to confirm your findings?
Ma'am, we went ahead and did a chest X-ray and a bedside EFAST for planning the further course of management. Ma'am, the chest X-ray, as seen in the picture, revealed a hydropneumothorax presentation. Ma'am, the arrows denote the pleural lines, the apex and the base. And ma'am, there was also a rib fracture on the 9th and 10th rib noted, which is not visible in the image due to a poor quality of the image.
And so what is that fluid collection? There is a sign, there's a,
yes.
So what is it known as?
On EFAST, we found a barcode sign in the apical region confirming the pneumothorax component, and free fluid was noted in the base, and around 300 to 400 ml fluid was present in the base.
If there was no pneumothorax in a normal person, what kind of an ultrasound picture will you get?
The sign would be seen, ma'am, due to the sliding of the pleural.
Yeah, and if you can go back to the chest X-ray.
Yes, ma'am.
What is that sign known as, of the pleural effusion?
Ma'am, the barcode sign or the seashore sign, ma'am?
No, in the chest X-ray.
Ma'am, yes, ma'am, air fluid level.
So a little bit of mental block, right? We are good at doing that, examiners. Yeah, continue. No marks taken off. Okay. I know how to make you nervous. Yeah, continue.
Ma'am, the patient management, ma'am, as we discussed, we went ahead with the primary survey, vital monitoring, oxygenation. Ma'am, IV cannula I secured, blood group cross-matching samples were sent, routine samples for complete blood count, liver and kidney function tests were sent, IV fluids were administered to prevent any dehydration and compensate any pre-existing. Patient was prepared for the chest tube insertion, and a written informed consent was obtained from the patient itself.
Okay. So can you tell me a few indications of placing an intercostal drainage system?
Ma'am, the indications, ma'am, primary would involve a pneumothorax with more than 30% of the hemithorax. Ma'am, there could be any pleural effusion, blood collection, a hemothorax, chylothorax, or even empyema to drain any of those. Or ma'am, like in our case, a hydropneumothorax presentation.
So what does it basically do? You place a intrapleural drain, and what is the mechanism? It is both therapeutic and diagnostic, right? When you place a chest tube, it acts in both the ways. It is life-saving. It's a very simple procedure, but it can, if done correctly and properly at time, it saves many lives. So what is the basic mechanism and the principle of?
Ma'am, the placement of an intercostal drainage system will help in restoring the negative intrathoracic pressure.
Of doing a chest tube drainage. Okay, I'll give you a clue. What? Shreyash, are we audible?
Ma'am, I think there was an internet issue.
Yes. Now we can continue. So what is the normal intrathoracic pressure and how is it generated?
Ma'am, the normal intrathoracic pressure is around -5 centimeter of water, and ma'am, it is subatmospheric, and during an inspiration, ma'am, this
inspiration and expiration.
Ma'am, during inspiration, ma'am, this decreases further to -8 centimeter of water, ma'am, due to the contraction of the inspiratory intercostal muscles and the diaphragm. A negative pressure is created, which helps the lungs expand. And during expiration, this goes to -4 centimeter of water, which promotes in the expiration phase.
Yes, one is the contraction of the chest wall, and another is the capillary pressure, attractive pressures between the visceral and the parietal pleura, which creates a negative intrapleural pressure. So there are conditions where this negative intrapleural pressure is disrupted. Can you tell me the conditions?
Ma'am, the negative interpleural pressure could be disrupted, ma'am, in case of any chest wall deformities or a fracture or any penetrating trauma could disrupt it. Ma'am, any accumulation of fluid, blood or chyle or pus could disrupt it, and even the presence of a bronchopleural fistula could disrupt the pressure.
So placement of a intercostal drain, we try to drain out this fluid or whatever is being collected there, and then restore the lung to its normal function. Yeah. So how do you place a chest drain?
Ma'am, for placement of chest drain, ma'am, first we would like to position the patient, ma'am, which would be preferably in the supine position. Ma'am, we would get the patient to be comfortable, and we would abduct the ipsilateral arm with the elbow flexed over the head, so as to expose the area that we will be choosing. Ma'am, we will identify the boundaries of the triangle of safety. And then, ma'am, we will clean and drape the patient because we must follow an asterile aseptic technique. We will clean the area using a chlorhexidine swab. Ma'am, then we will identify the fifth intercostal space, which is the preferred site for insertion using a landmark technique. And ma'am, then we would go ahead with the procedure.
Tell me very briefly about the procedure.
Ma'am, we will start the procedure. Ma'am, we go in the fourth or the fifth intercostal space on the superior border of the lower rib, and ma'am, we use a Z technique wherein we create a flap of skin so as to avoid any air cavities found when we'll be removing the tube. Ma'am, we'll first insert, we'll inject a 1% lignocaine so as to provide local anesthetic to the region. And then using a scalpel, we'll provide a stab incision on the site where we want to insert the tube. Then using a forceps, we'll do a blunt dissection through the skin, subcutaneous and the muscle layers. Then using a finger, we will dilate further and pierce the pleura and perform a sweeping motion inside so as to check for any adhesions and check for the lung. And then we'll go ahead with inserting the chest tube, wherein we'll clamp the distal end of the tube so as to avoid any air entry during insertion. And then we'll place the chest tube through the forceps so as to avoid any injury to the lung. And then we'll guide the chest tube into the lung.
Okay, so what are the three essential components to achieve a water seal drainage system, or three essential components of a drainage system?
Ma'am, a drainage system, ma'am, it consists of three main things: a chest tube, the connecting tube, and the closed drainage system. The chest tube will be inserted in the patient, and then there will be a plastic connecting tube between the chest tube and the drainage system. And then the drainage system can be a 1, 2, or 3 bottle system or an integrated system.
Can you tell me just one point each, the advantages and disadvantages of these systems? There is one more system, a 4-bottle system, right? Very briefly, so that everybody can understand. Yes.
Ma'am, a single chamber underwater seal is, ma'am, the simplest and the first that was started with. Ma'am, it consists of a chamber wherein the tube from the patient end is submerged in water, and 2 centimeters submersion is there. This provides a one-way valve, a water seal for the air to pass out. This is most commonly used in a pneumothorax patients and works primarily on gravity.
And what is the difference between the patient and the placement of this collection chamber?
We ensure that it is 100 centimeter below the patient's level, for which the connecting tube is generally 1.8 meter in length, so as to facilitate the same.
Why 100? Why not 80? Why not 60?
100 centimeters provides enough difference hydrostatic pressure that will be needed to in case of a obstructed inspiration, a deep inspiration, ma'am, the fluid will not go back into the lung. It provides a good seal. Yes, to simply put it, if you put a collection chamber 100 centimeters below, it will exert a pressure of, generate a pressure of 100 centimeter of water, negative 100 centimeter of water. And any obstructive inspiration generates maximum up to negative 80 centimeters of water. So even if that happens, it will not, the fluid from the chamber will not enter the chest cavity. So this amount of difference is required. So this is gravity dependent drainage system, right? So can we go to the
And what will happen? Yes, what will happen if the drainage tube is submerged more than 2 centimeters inside the fluid?
Ma'am, like in a one bottle system, ma'am, that's one of the major downfalls of the one bottle system. For example, if there was a concurrent pleural effusion, the fluid would also drain into the same bottle, which would cause the increase in the level, which would cause a further increase in work of breathing for the patient that the patient would have to overcome. And slowly the drainage that was happening would reduce. So we came up with a 2-bottle system wherein the first chamber was a drainage collection bottle. And then the second chamber provided the underwater seal, which would be a constant 2-centimeter seal. This would reduce the need of having to change the bottle again and again.
Then what is the disadvantage of this?
And the disadvantage primarily is in this case, ma'am, because the first chamber acts as a reservoir in addition to the lung. So the evacuation of air, like a pneumothorax, becomes more difficult because the patient has to overcome this pressure as well. And we don't have a provision of a suction control in this, so we cannot attach suction. So drainage of fluid is easier, but for air, it becomes difficult, for which we came up with a 3-bottle system.
Yes, yes.
And the 3-bottle system, the third chamber added had an open valve to the room air, and a wall suction was added. The submersion of the pipe to the room air controls the suction pressure for our patient's system. The wall suction it's independent of the wall suction, ma'am. It can be anywhere between 10 to 20 centimeters of water, depending on the need of the patient.
Okay, so you said 20 centimeter of water, negative 20 centimeters of water. So what happens if we drain pleural fluid or pleural collection at a very fast rate? What happens?
One of the major complications of drainage is a negative pressure pleural effusion. Ma'am, in case of rapid evacuation of the fluid, ma'am, since there will be a sudden change in the pressures, ma'am, there can be a pleural effusion due to the expansion. Ma'am, to prevent this, we generally limit a maximum of 1 to 1.5 liter in one go. And then there's the recommendation of clamping the drain for an hour after a liter of fluid has been evacuated.
Correct. So in this system, if for some reason the suction is switched off, so there is no way the patient can, there can be no drainage of pleural fluid or air.
And that would cause
yeah.
Which could cause tension pneumothorax in the patient due to the increasing.
So the next level was?
And a four chamber system wherein we added a 4th bottle, which would act as a vent in case of a suction failure.
Right. But the 3-bottle system and the 4-bottle system, it is very bulky.
Yes,
right? It is very noisy. It will be very difficult for the patient to move around with this system. So came the
integrated system, the local system, which has all the components in one, and it is easy for portability. Ma'am, it has a collection chamber inbuilt with the markings, which helps us see how much fluid has been drained. It has an air leak monitor to see if there is constant leak of air. Ma'am, the suction can be controlled using a regulator, and there are release valves for pressure, and there's an automatic valve. Doesn't need a air water seal.
Yeah, the reservoir just has to be changed whenever it gets filled up, and we can keep on monitoring. So once you have inserted the chest drain, what will be the criteria to remove it?
Ma'am, the criteria for removal, ma'am, primarily would be, ma'am, in case of pneumothorax, ma'am, we go for repeated chest x-rays wherein we see the expansion of the lung. Once the lung is adequately expanded and there is no air coming out of the chamber, 24 hours after that, we can remove the chest tube. In cases of hemothorax or a pleural effusion, ma'am, if the drain output has completely stopped, then we can go for it. Or if it is less than 100 ml per day, then also we can think of removing the chest drain.
So now the patient was in ICU, right? The patient needs to go for a CT scan, and the patient was supposing in 3-bottle system. How do you take the patient to the, or I'd rather say not a 3-bottle system, water seal drainage system? How do you transport this patient to the CT scan area?
Ma'am, while transporting, ma'am, we must ensure 2 things: that the drain system, that the chest tube is not clamped, Ma'am, we'll first of all see that all the points are sealed, are connected properly. There are no leaks in the system. Then we will see that it should not be clamped while the transport, and we'll ensure that the drainage system is 100 centimeter below. So because if it is above or at the level of the patient, there's a risk of the fluid going back into the system. So these three things, ma'am, we'll monitor.
Even for some reason, if it is clamped, then always be very vigilant to unclamp the tube,
Yes, ma'am.
right? Anything else? So and what about the role of antibiotics?
Ma'am,
Should
antibiotics.
patients receive it?
Ma'am, antibiotics are normally not indicated, but in our case, since the patient was with trauma to the chest, ma'am, to reduce the chances of infection and pneumonia, we can use a first generation cephalosporin regimen.
Okay, so thank you. Your viva went well. Maybe Dr. Vinit would now like to summarize the findings.
Thank you, ma'am.
Good afternoon, everyone. Good afternoon, everyone. I'll be summarizing intercostal drain. So to summarize or the key points, why do we push the chest tube? To evacuate air or fluid into a closed collection system, to restore negative intrathoracic pressure, promote lung expansion, prevent lethal levels of pressure from developing in the thorax. Indications of an ICD, primary indications, it can be a large or symptomatic pleural effusion, significant pneumothorax more than 30%, other pleural collections like empyema, hemothorax, chylothorax, secondary indications to do pleurodesis with sclerosing agent, and in postoperative cases like thoracotomy. Contraindications of an ICD, there are no absolute contraindications in the presence of overriding primary indications. Relative contraindications can be coagulopathy, pleural adhesion, and local site infection. So prior to insertion, what point should we take care of? First one is analgesia. We should provide analgesia with local anesthetic infiltration with 1% lignocaine. Various studies have shown that the use of prophylactic antibiotics with the chest trauma decrease the incidence of post-traumatic empyema and pneumonia. However, the use of prophylactic antibiotics are not recommended in non-trauma patients. Patient position, it can be semi-reclined with hand behind the head, sitting up leaning over the table, and lateral decubitus. The sitting up leaning over the table position is generally used to drain pus and blood. So where should we insert an ICD? It is ideally inserted in 4th to 5th intercostal space in the anterior to mid-axillary line. Second intercostal space in the mid-clavicular line is particularly used for apical or tension pneumothorax. We should insert the ICD in the superior border of the underlying rib to prevent any damage to neurovascular bundle. So the site of insertion, we should insert in triangle of safety, which is bounded anteriorly by the lateral edge of the pectoralis major, posteriorly by the lateral edge of latissimus dorsi, superiorly or the apex is formed by the base of axilla, and the base is formed by the 5th intercostal space. What size of an ICD should we use? So for blood, to drain blood or pus, we should ideally use a larger French of the ICD, 24 to 36 French. And for air, we can use smaller French ICD, 16 to 24 French. Complications. Insertion of an ICD can cause injury to the intrathoracic structures like lung, cardiac structures, abdominal viscera. It can also cause diaphragmatic injury, hemothorax or pneumothorax. Infection, it can cause pneumonia or empyema. Other complications like subcutaneous emphysema and re-expansion pulmonary edema. So coming to the principles of ICD, airflow in an intercostal drain is governed by changes in the intrapleural pressure. So in a spontaneously breathing patient, the negative pressure during inspiration causes the water level in the tube to rise slightly. The positive pressure during expiration pushes the air and fluid out of the pleural space into the tube in the collection bottle, and hence the air bubbles out of the tube into the underwater seal. The fluid is drained by gravity. It mixes with water and raising the fluid level. Now the bottle systems, as already discussed in the case presentation, we have one bottle system in which there is single bottle for both underwater seal and collection chamber. The main disadvantage of this bottle system is as the bottle fills, the drainage decreases and it increases the resistance and hence increase the work of breathing. The two bottle system, there are separate collection chamber and separate underwater seal chamber. It overcomes the disadvantage of one bottle system. The three bottle system, there are three chambers. First one is the collection chamber. Second one is the underwater seal. And third one is the suction chamber. So the main key points. So in a three bottle system, the main advantage is we can apply a suction pressure of -15 to -20 centimeters of water, which will hasten the drainage of pleural effusion and the resolution of pneumothorax. The disadvantage of this system is it is very complex and there is a risk of accidental pneumothorax if suction fails. So in the key points in all the three bottle systems are, they all have underwater seal, which provides as a one-way valve. It produces the siphon effect, which helps in enhanced drainage. The drainage tubings, it is 1.8 meter or 6 feet long and 9.5 to 12 millimeters of internal diameter. The distal end of the tube is 2 centimeters below water. More than 2 centimeters can be too difficult to expire against, and less than 2 centimeters is an ineffective seal, meaning air could enter the pleural space. Next one is the collection chamber is always kept 100 centimeters below the chest. Why is it so? To prevent water from being sucked up into the chest, usually the height of 100 centimeters is sufficient to allow for negative pressures as high as 80 centimeters of water. The collection chamber should have a larger diameter, ideally of 20 centimeters diameter. It provides minimal resistance to drainage of air and also prevents the loss of underwater seal as water moves up the drainage tube during a deep inspiration. So after an insertion of ICD, what are the concerns and how to troubleshoot them? The first one, what we see in ICUs is column not moving. So what can be the cause of that? It can be clot or obstruction, kinking of tube, false passage of the tube, fluid-filled dependent loop, and if the lung is completely re-expanded. How do we transport a patient with ICD? So always keep the drain below the level of the chest, and while moving the ICD in the bottles, we put a clamp. And please remember, whenever the ICD is bubbling, do not clamp it. Next thing what we see is air leak. So it can be due to a migrated tube with drainage hole outside the chest wall. In those cases, we should visually inspect the ICD. A continuous bubbling ICD, we should suspect bronchopulmonary fistula. In these cases, we should have a chest X-ray to look for surgical emphysema, the holes of the ICD, and pneumothorax. So how to avoid re-expansion pulmonary edema? The suggestion for this are, we should clamp the tube for 1 hour after 1 liter of drainage. Not more than 1 to 1.5 liters should be drained at one time, and 500 ml can be drained per hour. So what should we do if there is accidental disconnection of the ICD? We should clamp the tubing close to the patient chest, reconnect with a sterile tubing or new drain, unclamp and restore the drainage. How an ICD should be removed? It should be removed when it is no longer indicated, that is when the lung is fully expanded or it is not functioning anymore. It should be removed at breath holding, that is at end inspiration or end expiration, or use Valsalva. It should be removed by smart pull, that is, it should be removed swiftly or quickly. The sutures are placed and occlusive dressing are placed post removal, and it should be followed up with chest X-ray. Anesthesia in a patient with ICD, the key points to remember are: ensure functioning ICD before induction. Do not remove ICD before induction and mechanical ventilation. Avoid PEEP, avoid nitrous oxide, and provide adequate pain relief for the ICD side. Some of the chest X-ray post ICD insertion. So this one is a chest X-ray showing a large pneumothorax with a large chest drain is positioned with its tip pointing superiorly within the pleural cavity. If we have a close look at this chest X-ray, we can see the tube has a radio-opaque tip and there is a marker strip with gaps in the marker that indicate the position of the hole in the side of the tube. But chest drains are variable in drains. Some ICDs do not have it. The next chest X-ray is showing a large pleural effusion and ICD is placed to drain the pleural effusion. The next chest X-ray shows complication of ICD placement, that is iatrogenic pneumothorax. So the patient presented with a pleural effusion, and ICD was placed to drain the pleural effusion. The effusion, which was very large, has been nearly completely drained, leaving only a small residual infusion, as you can see here. Injury to the lung at the time of drain insertion site has led to the formation of a large pneumothorax. The next complication is surgical emphysema. As we can see in this chest X-ray, the drain tube was placed, but it was placed inappropriately. So the chest drain is located within the soft tissue, and there is pneumothorax and a widespread surgical emphysema over the left chest wall. So that's all to summarize ICD. Thank you and have a nice day.
Then I saw 5 minutes. How much time did we exceed?
Thank you, ma'am. Thank you, Dr. Vinesh, for beautifully summarizing it all. There are no questions as of now in the chat box, ma'am.
Okay.
You can close the session, ma'am.
Thank you so much. Yes.
Thank you so much, ma'am. Thank you for
Thank
being
you.
a part of APPEC2023. Thank you for your contribution. So we will move on to our next session, and I would like to invite the chairperson for the next session. We have Dr. Harish C. Sachdeva. Sir is professor and consultant at the Department of Anesthesia and Critical Care in VMMC and Safdarjung Hospital, New Delhi. And sir's area of special interest is critical care. We welcome you, sir. And I hand over the proceedings of the session to you, sir.
Good afternoon, everyone. I would like to request the host to start the video session.
Okay, ma'am.
Good afternoon, everyone. The topic